So we will start with House File 3423, Representative Hicks.
Good morning, chairs and committee.
Good morning. Please move your bill and proceed with your testimony.
Okay, so the bill in front of you does have an amendment that we are awaiting on for you to be able to see. So just wanting to make sure you see that as we get that printed. The amendment does some things that cleans up some language and also makes sure that this works in a variety of different ways, expanding, like, for example, one of the things that the amendment does is instead of talking about cash on hand, it talks about financial stability, for example, because it may not, it may look a little bit different. When you see the amendment, you can see some of the changes. The heart of this bill is really to tighten up enrollment, making sure that enrollment is done in a way that ensures that we are getting providers who are comfortable with doing the service, but who can do the service and can demonstrate that they can do the service. I think one of the things that I learned during this prepayment review and pause is that when providers were not financially secure, it was our clients and our workers who suffered. People didn't get paid or people didn't get cared for. Both of those things were bad for the folks who are most vulnerable. And so this bill works to make sure that our providers can do those things consistently. I am happy to go through the different portions. I do wish we had the amendment in front of us because it does, change quite a few things. I do want to thank Chair Knorr and Chair Schumacher for sitting down with me and their teams to go through and talk through the things that they also saw as important, so we could work collaboratively to make sure we put forth the best bill for individuals to get the services they need and to protect workers, individuals, and Minnesota taxpayers. So, Chair Knorr, would it make sense to just open up to questions while we wait for the amendment, or do we need to move the amendment? I'm sorry, I'm not sure what to do in this situation.
Thank you so much. Representative Hicks moves House File 3423 to be laid over for possible inclusion. With that, I wanted to ask if nonpartisan can just walk us over the House research, and we will wait for the DE for adoption. Representative Beck.
Yeah, it's just a suggestion. Is there that many changes, or could we just do it orally?
It's many changes.
Okay, very good.
We had almost an entire team working over the changes. We've got a similar bill introduced by Chair Schumacher and also
just wanted to know.
So it's a DE.
Okay, very good.
Please introduce yourself and proceed.
Thank you, Mr. Chair. I'm Annie Mock with House Research. So I'm going to walk through the DE1 to House File 3423. And just to sort of set the table here, there are two buckets of changes in this DE1. One are the changes that Representative Hicks requested that are made to how providers get enrolled into MA. But the other set of changes is related to recodification of current statutes. So under current statutes, all of the changes or all of the requirements governing provider enrollment are in one small subdivision. And so what this DE1 does is sort of pulls those out of their current place and puts them into new sections to make it a little bit easier to follow the requirements. So you'll see both sets of changes in this DE1. So the first three sections of the DE1 are all just technical changes, updating cross-references related to that recodification I mentioned. Section 4 of the DE1 requires that DHS include in its annual report on MA information about all of the sort of site visits that conducted, pre-enrollment, post-enrollment, and unannounced site visits in the previous fiscal year. This is all new language that's being added in the DE1. Section 5 is where you'll see the recodification. So Section 5 is in current statutes, is where all of the provider enrollment requirements are. And you'll see that all of those requirements get moved under the DE1. So then Section 6 is all about provider enrollment. It creates a new section of statutes. The first subdivision designates categorical risk levels. You've probably heard about these risk levels where provider types have to be categorized as either limited, moderate, or high risk. So this language is largely just a recodification of current statute with some technical modifications. Subdivision 2 adds a number of different verifications and checks that the commissioner will have to do when enrolling providers into MA. A lot of these verifications and checks are in federal regulations, so the state currently has to comply with them, but we're now adding them to state statutes. Subdivision 3 has to do with background studies. It requires the commissioner to conduct background studies for all providers applying to enroll in MA, and also requires background studies for a number of individuals who are employed by the provider. So those are any individuals with an ownership or control interest in, or who's an officer, director, agent, or managing employee of the provider. The section also provides, or the subdivision, excuse me, also provides that fingerprint-based background studies are required when mandated by federal law or when a provider is designated as moderate risk or high risk. And the section, or the subdivision, also allows the commissioner to conduct post-enrollment background studies as necessary. A lot of this language is, again, recodification of current language, but with some substantive modifications. Subdivision 4 has to do, or requires that providers enroll each provider-controlled location where they're providing direct services into the program, and also provides a few exceptions for certain types of locations. Again, this is largely a recodification of what's in current statutes. Subdivision 5 has to do with site visits. It requires that providers allow CMS and DHS to conduct unannounced site visits at any of the provider's MA-enrolled location. And it also directs the commissioner to conduct certain site visits. So for each MA provider that is considered moderate or high risk, the commissioner will have to do pre-enrollment and post-enrollment site visits. And then for all providers, the commissioner will conduct unannounced site visits at certain time periods. And this is largely, again, a recodification of what's in current statutes with some modifications, particularly around those unannounced site visits. Subdivision 6 requires that a provider purchase a surety bond as a condition of enrollment in MA. This language is largely, again, recodification of current law, except that under this language in the DE1, the purchase of a surety bond is required in certain circumstances rather than something that the commissioner may require. Subdivision 7 has to do with the financial capacity that Representative Hicks mentioned. It requires a provider to demonstrate sufficient financial capacity as specified in order to enroll in MA. This is new language. Subdivision 8 has to do with compliance programs. It allows the commissioner to require, as a condition of enrollment in MA, that an MA provider establish a compliance program. And then it specifies that the provider has to designate someone to be the compliance officer and specifies what duties that person has to carry out. This is largely just a recodification of what's in current statutes with a few small substantive modifications and a few technical modifications. Subdivision 9 has to do with incomplete provider enrollment applications. It directs the commissioner to deny a provider's application in certain circumstances. This is a recodification of what's in current law. And subdivision 10 requires the commissioner to deliver correspondence and notification other than those involved with background studies directly electronically to a provider. And this is just a slight change from current statute, making that electronic notification a requirement rather than permissive. Moving on to section 7, this has to do with when providers are revalidated to continue enrollment in MA. Subdivision 1 just is technical language providing that the commissioner must revalidate each MA provider according to this section. Subdivision 2 lays out the schedule for how, when the commissioner has to revalidate providers. This is largely a recodification of what's in current law with a change to provide that when a provider is designated high risk, that revalidation needs to occur every 3 years rather than at the discretion of the commissioner. And then subdivision 3 provides the procedures that the commissioner needs to follow when, revalidating the providers. This is again largely a recodification of what's in current statute, although it does add that revalidation must include unannounced site visits at each of a provider's enrolled locations as part of revalidation. And it also provides that financial capacity that the provider has to demonstrate upon enrollment, they also have to demonstrate at revalidation. Subdivision 8 has to do with when providers can be suspended and terminated. So subdivision 1 this is section 8, apologize for that. But section 8, subdivision 1 requires that the commissioner suspend a provider's ability to bill if the provider is not in compliance with program requirements. It also provides that suspension has to be in place until the provider comes into compliance. Subdivision 2 allows the commissioner to revoke a provider's enrollment if the provider fails to maintain and provide the commissioners access to certain types of documentation that are specified there. And this is largely just a recodification of what's in current statute. Subdivision 3 adds new language to state statute it's largely federal requirements governing when the commissioner must terminate or deny a provider's enrollment in MA. So that's in paragraph A. It's a very long paragraph, but again, a lot of the information in that paragraph is currently in federal regulations and it's just being added to state statutes. And then paragraph B allows the commissioner to exempt a rehabilitation agency from certain types of termination or denial in certain circumstances. And this is just a recodification of what's in current statutes. Section 9 provides that it gives the commissioner the authority to withhold payments for a 90-day period if a provider, upon enrollment, is in one of those high-risk categories. And this is just a recodification of what's in current statute. Section 10 is all new language in Section 10. Subdivision 1 allows the commissioner to issue a statewide or regional provider enrollment moratorium for up to 24 months for any provider type that is designated as high risk. And it also directs the commissioner to revalidate the enrollment of each provider that's subject to that moratorium before the moratorium ends. Subdivision 2 provides that for any provider that's subject to that moratorium that's already enrolled in MA, they can continue to enroll new clients and beneficiaries. Subdivision 3 is a notice requirement directing the commissioner to issue notices to enrolled providers and the legislature at least 10 days prior to implementing an enrollment moratorium. And then subdivision 4 directs the commissioner to submit a report to the legislature about that moratorium within 60 days of ending it. Section 11 has to do with specific enrollment requirements for providers or suppliers of durable medical equipment. This is all a recodification of what's in current statute. And then subdivisions 2 and 3 have to do with requirements for providers that are licensed by the Commissioner of Human Services under 245A or licensed by the Commissioner of Health. Again, this is all just a recodification of current statute with a few technical modifications. Subdivisions 12 through 14 are all technical. They're updating cross-references having to do with the recodification. And then section 15 is new language that directs the commissioner to amend Minnesota rules to update the definition of fraud with the correct citation to a federal law. And that is the DE1.
Thank you so much, Ms. Mack, for the overview of the DE1, and we have testifier online, so we'll get going with the testimony from the online testifier. Please introduce yourself for the record and proceed with your testimony.
Hello, thank you, Chair and members of the committee. My name is Joel Bakken, and I serve as Executive Director of Solutions Behavioral Healthcare Professionals. a nonprofit community mental health center serving East Grand Forks, Moorhead, Detroit Lakes, Fergus Falls, Alexandria, and St. Cloud. For more than 26 years, we have provided a comprehensive continuum of community-based mental health services. We were also among the first providers to deliver EIDBI when the benefit was launched in 2014. Solutions is accredited by the American Psychological Association and the Behavioral Health Center of Excellence. Those accreditations required rigorous review of our clinical services, billing practices, governance, and compliance systems. We opened every aspect of our organization to independent scrutiny, and when Minnesota DHS contracted with Optum last year, we voluntarily underwent an additional national compliance audit to ensure we met every mental health and EIDBI standard. We took that extra step because of Solutions' challenging and burdensome history with Optum. HF 3423 requires current EIDBI providers to maintain a 90 days of payroll reserves to pass revalidation. That requirement assumes EIDBI organizations are operating with substantial margins. We are not. We operate on tight budgets and reinvest in staff training, clinical supervision, and high-quality programming for these children. The bill also requires a surety bond, but a surety bond does not prevent fraud. If this legislation is focused on strong fiscal responsibility and meaningful oversight for MA providers, I stand with you. What I cannot accept is the idea that credible EIDBI providers must bear the burden of fixing DHS's fraud problem. Solutions does not rip off the state. Our clinicians and behavioral staff show up every day with professionalism, compassion, and deep commitment. We provide these services with integrity. Minnesota absolutely must prevent fraud, but if the data being publicized is inaccurate or lacks context, we cannot clearly define the problem, let alone solve it. Suggesting that 90% of claims are flagged without clear explanation risks equating flags with fraud or abuse. Inaccurate reporting creates confusion, damages trust, and destabilizes a system families rely on. Let's pursue excellence. Let's pursue accountability grounded in accurate and transparent information. And let's ensure that oversight strengthens rather than undermines access to high-quality care for Minnesota's children. Thank you.
Thank you so much, Mr. Berkin, for your testimony. We have two more testifiers here, Ms. Donahue and Mr. Skelton. If you can proceed to the testifier table and begin your testimony. Please introduce yourself for the record and proceed.
Chair Knorr and the members of the committee, thank you for allowing me to testify. My name is Sandra Bond. I got married, so it used to be Donahue. President of the Marsh, Minnesota Association of Residential Service Homes. I am testifying on behalf of our membership, which represents adult foster care and community-based residential service providers across Minnesota. Marsh must respectfully oppose HF 3423 as currently drafted. While we support strong program integrity standards and responsible stewardship of medical assistant funds, the bill expands provider enrollment requirements at a time when residential providers are already facing significant financial strain due to Minnesota's transition to a flat rate reimbursement system. The combined effect of expanded regulatory requirements and reduced reimbursement flexibility creates a structural mismatch that threatens the stability of small, community-based providers. Under prior rate methodologies, administrative and compliant costs were recognized within rate calculations tied to service needs and operational realities. Under the current flat rate structure, providers received a fixed reimbursement regardless of resident acuity, administrative burden, or compliance expansions. The bill proposes enhanced enrollment standards, expanded screening obligations, possible compliance officer requirements, and increased documentation and revalidation expectations. These requirements carry real administrative and financial costs. As a result, provider must divert already limited direct care dollars to new compliance infrastructure. For small adult foster care homes operating on narrow margins, there is no ability to absorb these additional obligations without impacting staffing, wages, or care quality. Marsh represents many small family adult foster care homes serving 1 to 4 residents. These providers are not large healthcare systems with compliance departments. The owner is often the caregiver, administrator, scheduler, and payroll processor. HF 3423 applies expanded enrollment and compliance expectations uniformly across provider types without differentiation. For small 245A licensed residential providers, the bill risks imposing corporate level compliance standards on home-based operations that lack administrative scale. Under a flat rate system, small providers cannot spread compliance costs across multiple sites or revenue streams. This creates an uneven burden that will disproportionately affect precisely the community-based Minnesota settings Minnesota has historically sought to preserve. Minnesota is already experiencing adult foster care closures, workforce shortages, and recruitment challenges. Adding new enrollment hurdles and compliance risks without corresponding reimbursement adjustments may accelerate provider exits. When a residential provider loses enrollment or cannot economically comply, residents do not simply lose paperwork, they lose their homes. Displacement of vulnerable adults due to administrative strain undermines the very goals of a medical assistance oversight. This bill, when combined with flat rate reimbursement, increases the likelihood of provider attrition, consolidation into larger corporate entities, reduced access to small community-based services, and service disruptions for vulnerable adults. If the legislature expands regulatory requirements, it must ensure that reimbursement systems reflect these obligations. Implementing enhanced compliance structures in a flat rate environment effectively creates an unfunded mandate. Marsh is not arguing against accountability. We are raising concern about timing and structural alignment, expanding enrollment and oversight requirements during a period of rate compression risks destabilizing an already fragile network. Marsh urges the committee to pause or amend HF 3423 until its fiscal and operational impact on flat rate residential providers can be evaluated. Thank you for your consideration.
Thank you so much for your testimony. Ms. Skelton, please introduce yourself for the record and proceed.
Chair Knorr, Representative Hicks. My name is Ellie Skelton. I'm the Executive Director at Touchstone Mental Health. And it sounds like the 90-day payroll thing might be fixed in the amendment, so that shrinks my testimony to 45 seconds. So that's good. I appreciate her willingness to work on enhancing program integrity. I'm the Executive Director of Touchstone Mental Health. I said that, I think so. Okay, the two areas that I have some concerns with is the surety bond language, the $100,000 or 10% of Medicaid billing. If we could look at that threshold, we hold a lot of insurance already, professional liability, umbrella insurance, employee dishonesty, cyber liability insurance. Insurance costs have been skyrocketing. Luckily, cyber liability hasn't been continuing to escalate so high, but adding an additional, I would just suggest, could we look at lowering that percentage? We provide 98% of who we serve as low-income Minnesotans with serious mental illness, mostly Medicaid or PMAP billing. So if we could just look at that, maybe not 10% of your Medicaid payments. We operate basically a break-even business. So every additional cost, it comes from staffing. And so, I don't want to lay off staff or reduce staffing. The other one I wanted to talk about was the moratorium language, new settings for existing providers. I just wanted to make sure that with respect to Section 16, that their clarification would be helpful to ensure that new settings or new locations for existing providers are allowed. As an example, Touchstone Mental Health has been working with Aon, a nonprofit housing developer, for 10 years on a housing project downtown. Luckily, 72 new units of beautiful, affordable housing will open in December of this year. If a moratorium unintentionally delayed or prevented long-planned projects like this from moving forward, that would be an unintended consequence. I just want to make sure that language is really clear that projects, especially in outstate Minnesota, sometimes it takes 3-4 years to get a project up and running. So that existing providers can add new settings and locations. I would just like to make sure that that's super clear, because sometimes it's the ambiguity of the moratorium and who it exactly applies to. I think that's all I have. Thank you for the opportunity to testify.
Thank you so much for your testimony. We have the D before us, so we've already walked through. Representative Hicks moves the adoption of DE1. Any discussions? All those in favor, please say aye. Aye. Opposed? The amendment is now adopted. To your bill as amended, final words probably, and then maybe discussion from members.
Yes, thank you so much. I appreciate everyone's testimony and their concerns. I understand that there are concerns around increasing oversight and regulation because it may increase cost. What I will say is that I'm open to more discussion, but we're sort of here because we keep doing that. I have watched as a parent and then as a legislator, anytime additional oversight or concerns are brought up, particularly around things that protect people and staff, the pushback from providers is always around the cost. And we as legislators hear that and want to respond and make that better, and so we adjust, and we end up here. This is how we got here. I would point out to you that in front of you today and in front of your testimony is not a single person who receives services. And I would remind you that in this committee, that is frequently the case. This bill is about protecting the people who receive services and taxpayers. And again, I would point out, there's not a single person who receives services here today. And I would challenge you all to think about how often you sit around this ring, and that is the case. If we are making changes to statute to protect people, we need to be centering people first and then making sure that we make the program work. And I think we can do that. I think there's absolutely room to have those conversations, but we have to start having them. And that is a hard thing to do. So thank you for your time.
Thank you so much, Representative Hicks. Mr. Chair, Chair Schumann.
Thank you, Mr. Chair, and thank you, Representative Hicks, for this, and thank you for the process that we've started on this one. Instead of having dueling bills and dueling hearings on very similar concepts, it was good to try and select one to have a path going forward. And I would just note that, at least from my intention, it wasn't the final word on this. We just wanted to have that path. And the feedback I've been getting already since the DE's been posted is a lot of it's technical, some of it's the policy piece, but a lot of it is technical that we can work to clean up. And so I'm glad to see that we're going to lay this over so we can continue working on it, and we will continue working on this. And one note from the testimony to point out is on the section 10 piece on page 16 that it's permissive language for the enrollment moratorium piece in there as we have it now. And I just wanted to make that clear on the record for that. And thank you again for your work on this.
Thank you, Chair Schumacher. I think this is the work that we do, and I wanted to appreciate the nonpartisan staff for their effort to get us here. This is more about pre-enrollment, post-enrollment, and also ongoing process. I know there are two sections which are not included in this bill that we promised Chair Schumacher will get to, the prepayment review process and also payment withhold. So those are two sections we're going to take a deep dive also. So this is a comprehensive bill. Representative Gandhi.
Thank you, Mr. Chair. Just one question. Maybe it's clear to everyone in the room but me, but I'm looking at the 12.6 and payroll for 90 days. To meet that requirement, would I need to have cash on hand, or would a standing line of credit available at the bank be sufficient?
Yes.
Representative Hicks.
Thank you, Chair. Yes, that was the change in the amendment because someone was like, we don't have cash. And I was like, valid. A line of credit is completely acceptable with the way that this language is written. Really the intent here is that if your payments are withheld for 90 days, you can pay your staff. Mm-hmm. The goal is to make sure that we don't have what we've seen, which is providers who did not have a line of credit, did not have cash, did not have opportunity. And so people lost services and people lost their jobs. And in some cases, I have heard of from direct support workers who were not paid for 2 or 3 weeks' worth of work because their business just closed and they never got compensated for the work they provided.
Representative Ganda.
Thank you, Mr. Chair. Nobody in this room likes a lot of regulation. You know, heavy top-down regulation from government is not a good thing. But we saw a vulnerability when we had that little payment lag. We saw a vulnerability that opened up for a lot of our people that receive these services, right? If that provider would go away for a 1 or 2 week lag in payment, we realized that was a vulnerability, and we do have a duty as policymakers to try to close that vulnerability. So I applaud your effort. Thank you.
And also that includes account receivable in that instance where they're waiting to be paid, so that will be counted. Vice Chair Gilman.
Thank you, Chair. And I just wanted to just make a quick comment. Thank you, Representative Hicks, for continued conversations in the interim as we've talked through a lot of these issues. I do want to note, I really do like the report to the legislature. I'm curious if in other parts of statute, maybe nonpartisan could say this, but the line in 16.32 where it talks about the commissioner must submit a report to the chairs and ranking minority members of the legislature committees. So I love that you would have a report come back to us within 60 days, no matter who's in sitting at the gavel. I appreciate that because that creates more transparency, and it's exciting to see that. So thank you.
Thank you so much. Briefly, Representative Hicks.
Okay, I want to give credit where credit is due. That was Chair Schumacher's idea.
With that, Representative Hicks renews her bill, that House File 3423 to be laid as amended, to be laid over for possible inclusion.